Okay, so welcome back, part two of my chapter 3 lecture. Sorry, this one's going to be a long one. There's just a lot to cover. Four main eras in U.S. healthcare evolution: pre-industrial, characterized by consumer sovereignty; post-industrial, professional dominance, corporatization, the process of corporatization; and then health reform. I'm not so sure that government dominance is the truth. But what did we know pre-industrial? Well, what dominated medicine was the theory of the four humors that was developed by Hippocrates back in 450 BC. This was state-of-the-art medicine. So when your book talks about through the mid 1800s, in Europe, scientific training, was the norm. This is the science that they were being trained on, right? So sure, I'd like to have a doctor trained that if you have a fever, it's because you have too much yellow bile. And so in order to fix that, what we need to do is bleed you to take care of your yellow bile, right? Or something like that. So it's, or if you're having, if you're having diarrhea or something else, we'll have to feed you some. So it's just a bunch of basically astrology, astrology might be actually more accurate than this kind of four humors application. But this was height of medicine, through the middle of the 19th century, right up into the Civil War. This is your university trained physician would have studied this and would have come to talk to you about, whether you were sanguine or phlegmatic, or, and did you have too much phlegm or too much black bile? And, and so if you had too much black bile, they'd give you a laxative so that you'd poop out your black bile. It's just craziness from our perspective, but this was the best they had, right? This was the height of the state of medicine. This is a cartoon of George Washington being bled. George Washington ultimately dies of an infection and a fever associated with that infection. I think it was an infected tooth is what actually kills him. And his physician was, the leading physician of his time, cutting edge physician. And what was his solution? To bleed him, right? Well, he had a fever, so we had to bleed him because he had too much yellow bile. And so there's quite a bit of discussion about, would Washington have survived, or was the bleeding itself part of why Washington perhaps didn't survive the infection? There was a whole theory of spontaneous generation, right? They did not understand that the reason maggots appeared on meat was not spontaneous generation in the sense of like they appeared out of thin air. That's what spontaneous generation basically means. It just like appeared because God, right? That's the motive. Spontaneously appeared, instead of the fact that flies were landing on the meat and laying eggs in the meat, and then and the maggots were fly larvae. They had this whole theory of spontaneous generation. Contagious diseases like leprosy were commonplace, and the way we dealt with them was to send them to isolation camps. This is Kalaupapa on Moloka'i. This is an island, part of the Hawaiian Islands. Moloka'i, it's a lovely island. You can see it from Oahu. This beach settlement that you see down here was a leprosy colony. So Hawaii has a very high rate of leprosy. Leprosy likes warm, wet, but not too hot, not too cold climate. And so leprosy is very common in Hawaii even today. It's Hansen's disease now is the more proper term. But what would happen is if you were diagnosed with leprosy, if the government decided you had this disease, right? If the medical society, the medical authorities decided you had leprosy, they would stick you in a prison pending the ability to put you on a boat. They would put you on a boat to Moloka'i. They would pull up along shore of Moloka'i, push you off the boat, and have you go to shore, where you would be part of the leper colony on Moloka'i. And it was truly, truly Lord of the Flies. There was no government. There were no police. So people would show up with some, maybe a chest of their things. They would get there, and as soon as they managed to wade to shore, they'd be robbed. And any food that they might have brought with them would be taken from them. So it was a pretty miserable existence. So healthcare in that situation, well, there was a gentleman named Father Damien who was a French Canadian priest, and he ultimately went to Moloka'i and joined the leprosy colony there, the leper colony there, and brought some order to the colony and provided care. They had no treatment for leprosy. We do today, but they didn't then. And Father Damien ultimately died of leprosy. So that's how we took care of contagious disease, is we isolated it, and it was quite brutal. And I go back to that point of, if you don't have the resources, this is the best they could do, right? It was brutal, but it was necessary. You had to isolate people who had leprosy. Otherwise, you'd get more leprosy. And there was no treatment. So what looks barbaric and cruel to us was just a cruel reality. As we progressed through time, we realized we didn't even know. We didn't have the germ theory of disease. And so we had this thing called, I can't say it right, it sounds like puerperal fever. And this was women who delivered babies in the hospital were at risk of getting puerperal fever. And it was deadly. A doctor named Ignaz Semmelweis, who was a German doctor, working in a facility that was divided between wealthy and poor. The poor were taken care of by nurse midwives. The wealthy were taken care of by the highly sophisticated and well-trained physicians. The physician on the physician side was a much higher level of much higher incidence of puerperal fever than on the midwife side. So if you were wealthy and getting this kind of higher level quality of treatment, you were actually more likely to die than if you were poor and getting care from the nurse midwife. So why would that be? Well, as it turns out, the physicians between patients, so between deliveries, would go back to the laboratory and do lab work, autopsies, and so forth. So they'd be cutting on dead bodies. In particular, they'd be dissecting and doing autopsies on women who had died from puerperal fever. And here's the thing that Ignaz Semmelweis discovered kind of by accident. If you washed your hands after you did your autopsy on a woman who died from puerperal fever, and then went back into the ward and put your hands inside of another woman who was having a baby, you were less likely to transmit puerperal fever to that woman. Now, they had no germ theory, so they had no idea that what they were doing was transmitting puerperal fever to their patients. And Semmelweis basically said, hey, let's wash our hands, between patients, and especially between handling dead bodies before we go back and handle live bodies. And the medical establishment pilloried him and, basically ran him out of town. But over time, we realized maybe there's something to this whole washing hands, antiseptic is what it's called, antiseptic behavior. And that's how we discover. That's how science, evolves, is by trial and error. And very often, the authorities don't accept change, which goes back to another reason why it's really important to have a market-based healthcare system, because markets are much more responsive to patients than governments are. So, pre-industrial era in the United States, medical practice was kind of all over the place, very primitive, right? For all the reasons we've just talked about. The United States was a poor country, right? Highly rural. People were distributed all over the place. Even if you happen to live in, say, a place like New York City, it was a slum, and we didn't understand healthcare. So even if you were, and here's my point, right? Even if you were getting care from the most sophisticated physician, it's likely he wasn't washing his hands after he went and did an autopsy. And so he was probably spreading germs and disease all over you. So seeing a physician, and then the best thing they could do is that theory, theory of the humors. So, if you've got cutting edge training in that kind of technology, you aren't that useful to begin with, right? So we had a lot of substandard medical education. It didn't really make that much difference. Because there wasn't anything to know, right? Healthcare, medical care, state-of-the-art medical care, just wasn't all that helpful. So we hit the 1800s, the Industrial Revolution takes off. We're seeing the impact of the Enlightenment and the embrace of science. We also have a whole lot of other things going on. But we also begin to see the medical societies developing and organizing. And what we see is the dominance of professions. And so the physicians get together and they create the American Medical Association, and then the American Medical Association starts to squeeze out anybody who hasn't done medical doctor training. So it used to be you had all these different kinds of doctors that would do different things for you. And the American Medical Association and the local medical societies began to squeeze out anybody who didn't look like them. I don't mean that like in a physical way, but like weren't trained like them. We had a lot of other factors going on. I'll let you read your text. I'm not going to belabor that. Science and technology begin to actually have some effect, right? We developed the germ theory in the 1800s. We start to understand that, we start to understand microbiology, and we discover penicillin and treatment for antibiotics and its antibiotic effects. First use of anesthesia. So if you were going to have an amputation prior to 1846, chances are they were going to strap you down, give you a good swig of whiskey, and then cut your leg off as fast as they can, because there was nothing they could do for the pain. 1847, aseptic technique. So this is the Semmelweis innovation, right? So we started to realize, maybe we should use clean bandages and, wash our hands between patients. We began to develop sterilization techniques. So instead of using the same bloody knife from one patient to another, we realized, maybe we should wash that between. Antiseptic surgery, same kind of idea, right? X-ray imaging. So you couldn't see what was going on inside the body until we discovered the X-ray. Penicillin, very late to the game, right? Very late to the game, penicillin. We also had a lot of, we'll talk more about public health later, but we had a revolution in public health that made probably more difference than anything else in terms of improving life expectancy, reducing mortality, and improving morbidity, right? The prevalence of disease. So we saw kind of the evolution and creation of the hospitals. We saw physicians getting a lot more cultural authority. And people started actually saying, physician can actually do something. It might actually be worth listening to him. Licensure really kind of comes about during this period, as well as, kind of the physician and hospital are kind of evolving together. So the history of the hospital comes out of the almshouse, right? So used to be basically if you were indigent, right, you didn't have enough money to support yourself, you'd get sent to an almshouse. That was also where you'd go if you were sick and dying and you weren't lucky enough to have, a daughter to take care of you. Whole series of reforms during the post-industrial era. The Flexner report really looks at the state of medical training. Again, more stuff for you to read in your text. We begin to see specialization in the United States. So at one point, everyone was a GP, everyone was a general practitioner. And over time, what we start to see are, specializing in surgeries. Surgery and medicine break apart into two kind of separate fields. And subsumed under the broader sense of medicine. But when I mean medicine, I mean the medical treatment, so the use of drugs and other therapies as opposed to surgery, cutting somebody. We also saw the evolution of mental health. Right? So we started to see the acknowledgement that mental health was an illness. I've asked you to read a bit about deinstitutionalization, and I think that's really important. Again, the barbarity of mental health institutions was largely a function of poverty, right? We didn't have the resources to take appropriate care of our people who had mental health disease. Not only that, we didn't really acknowledge that mental health was a disease. It was a flaw of character, for example, right? And that goes back to our model of illness versus disease. Community Mental Health Centers Act, right? So we had some laws saying, acknowledging mental health, right? And moving from just an illness to a disease. The Community Mental Health Centers Act of '63 creates, begins to try to reduce institutionalization. Again, I've asked you to read a little bit about that. So reducing institutionalization, creating the Community Mental Health Center Act. The idea was we would take all these patients out of asylums, put them back into society, and then give them care on an outpatient basis. A great goal, probably swung too far towards trying to manage things on an outpatient basis. Public health, like I said, has evolved quite a bit as we started to understand, particularly the idea of germs. When we stop thinking of, cholera comes about. Cholera is a disease that causes you to die from diarrhea. Stopped imagining that it was, that cholera came about as a result of bad air, right? Or that malaria comes about as a result of bad air. Instead, we realized that the vectors were parasites and bacteria. Parasite, in the case of malaria, parasites transmitted by mosquitoes, cholera, bacteria in the water. So public health begins to kind of separate it and become its own profession, separate from kind of traditional delivery of direct care. We saw the emergence of veterans services. Workers' compensation has an important role because it starts to kind of bring about health insurance. And what we saw was the emergence of health insurance in America. As we started to realize that medicine actually worked, that going to a hospital wasn't a death sentence, but that, the physicians who were going to be there providing care might actually be able to, had a better than 50-50 chance of doing something of value to you rather than hurting you. Um, uh, it became, more valuable to get that care. Improvements in technology, however, are expensive, and getting real training as opposed to the kind of bogus training that we used to see um, is expensive as well, right? And so how do you pay for a physician who has had to make a long investment in time and training? How do you pay a hospital for expensive equipment that it has to purchase? All those things make healthcare start to be more expensive. And so health insurance is a way to kind of provide a mechanism for paying for it basically in installments, right? So you pay a premium, and your premium is based on paying for care that you're expected to get over time rather than all at once, when you have an incident. So, rise of private health insurance. This is really important stuff. And I really want you to know this stuff. So, in particular, the story of the emergence of hospital insurance in 1929, the Baylor Plan. So the Baylor Plan emerged in 1929 because Baylor University Hospital. So this is the height of the Depression. People couldn't afford to go to the hospital because it was expensive if they had to pay for it all at once. So what they did instead was they came up with a plan that allowed you to pay in installments. And if you needed hospitalization, it was limited. I think it was 21 days. You could get up to 21 days of care per year, and you'd pay, $1 a pay period or something like that. And then you had the right to use the hospital. What this did was, instead of having one big expensive, hospital stay that may or may not happen, in which case, you'd break the bank trying to pay for it, you broke it into these little payments that became very much affordable. And so it became much more appealing. So it reduced that uncertainty that we don't like, that nobody likes, right? We talked about that cultural element of uncertainty avoidance. Insurance helps us avoid uncertainty. Nobody likes uncertainty. So this was the Baylor Plan became the model for Blue Cross. So you've probably heard of Blue Cross and Blue Shield. Blue Cross was hospital insurance. And then the California Medical Association created a plan for physician services that became known as Blue Shield. And both of those things still exist today. So when did health insurance become employment-based? This is another important moment in our history. Well, it came about during World War II, because during World War II, the government imposed wage freezes. So it was really expensive we were pulling all these people into factories. Instead of trying to bid up the cost of labor, we basically said, no, you can't labor, you can't negotiate for higher wages. And so employers still had to try to attract people as opposed to other employers. So what they competed on was, okay, we can't pay you more, but what we can do is add these other benefits, such as health insurance. And so health insurance became employer-based in the 40s, and then in 1948 it was legitimized, and then in 1954 a tax ruling basically said, yes, not only can employers offer this, but it becomes a reduction. It becomes a viable business expense for the organization, and any benefit that the employee gets isn't going to be taxed. So if you get benefits, financial benefits, or benefits from your organization, the organization you work for, and you can get taxed based on the value of those benefits. So in this case, in 1954, it was determined that health insurance benefits, so the fact that the employer was paying for part of it, wouldn't be treated as part of your income. So it becomes really valuable to you as an employee to have your employer pay for your health insurance, because that reduces your tax burden. So there was a bunch of efforts to try to create national health insurance. I'm going to let you read about these. They mostly failed. They have consistently failed until we get to the Affordable Care Act. Why do the people in the United States not like national health insurance programs? Well, your book has a bunch of reasons. Here's my variation on that. So I don't agree with a lot of the things that your book said, or I feel like your book kind of hits around the mark. But in reality, people like me don't like national health insurance because it's national. It concentrates power over 20% of the economy at the federal level. The United States was built on a system of checks and balances, a big part of which is there's a power sharing between the federal and state governments. Again, going back to those quotes I read you at the beginning, Madison and Hume talking about if we had angels running the government, we wouldn't need, to have checks and balances. Well, we don't have angels running the government, so if you're a Trump supporter, you probably think Biden is the worst thing since, worst thing. Well, sliced bread's great. So the worst thing since, the Antichrist. And if you are a Democrat and a Biden supporter, you think Trump was the Antichrist, right? So if you concentrate power at the federal level, you're going to have sooner or later, you're going to have somebody running all the programs that you care about in your life. That you don't like, right? And that group, or that individual, or that party will do things that you don't like. And so when we concentrate a lot of power at the federal level, it's dangerous, right? So that's one reason why people in the United States don't like national health insurance. It politicizes healthcare. Political control of an industry forces providers to appeal to politicians, whereas markets force providers to appeal to consumers. So Coca-Cola, if they want you to buy a Coke, they have to advertise to you. They have to make it cheap. They have to make it accessible. They have to make it taste good, right? They have to appeal to you as the consumer. But if Coke became the government, the national cola, then it would only have to appeal to the politicians that made decisions about how much money they got to make. And so they would stop worrying about what you as a consumer like, and they would worry about what the politicians like. And that's the problem. And another problem with a national health system is the providers are going to respond to their masters, the politicians, and not consumers. So again, when I was working in the military, one of the things that I saw over and over again was if you were higher rank, you got better care, right? Not necessarily better care, but your care was better coordinated, better organized. You were treated more nicely, right? So the care itself was probably about the same, but for example, again, at that Walter Reed Hospital I was talking about, there's a whole ward for executive medicine. So if you're a general or an admiral, or you're the wife of a general or an admiral, or you're the child of a general or an admiral, you get to go to the executive ward. Private rooms, higher level, more nurses per person, better food, so on and so forth. That care was about the same, but you got a lot more attention. That's government, that's government. That is an example of what happens when when providers are responding to political control, right? Why are they taking care of the admirals and the generals? Because the admirals and the generals are their audience, and they're the ones who can decide how much money the hospital gets, right? Whether the hospital commander gets promoted or not. Your book is in favor of reduction of variation. Generally speaking, reduction in variation, there's a lot of good to that. But the United States is a very varied country with a lot of different cultures, like we talked about within it, right? It's a huge landmass. And so the culture in rural Wyoming is quite different than the culture in Cambridge, Massachusetts, right? And what healthcare should look like is different between those two places because the cultures are different. And what is needed by the people in those places is to some degree different. There are commonalities, but there are some degree different. And so actually reduction in variation in some ways is good. In some ways it's not good. But when the federal government takes over something, it becomes a one size fits all. And that's not necessarily good. And then finally, shifting financing. So remember the financing function. So we had the quad functions, right? Financing function, just by shifting it from private pay, right? Private individuals paying into this a insurance company versus having it funded by taxes itself. This switch does not reduce cost in and of itself. So those are 4 reasons why people who are fans of market-based care don't like national health insurance. So let's talk a little bit about Medicare and Medicaid. Your book does a good job with this, so I'm going to kind of wing through it. But 1965, we saw the creation of Medicare. Medicare, so there's this interesting problem with anything that is designed for the poor. We tend to be pretty stingy with our government benefits for the poor. Culturally, the United States generally believes in a high level of agency, right? A high internal locus of control. So if you're poor, it's probably your own fault, right? I'm not saying that, but that's the culture that we live in, right? Is we have this high locus of control, and we basically believe if you're poor, it's your fault, right? And so in order to sell policies like Medicare, the baseline argument is it's a safety net, right? Well, the safety net implies that it's for somebody who couldn't otherwise take care of themselves. Medicare is a program for everybody who's over the age of 65, whether that's, somebody who's impoverished, maybe worked hard all their life, but never had a lot of education, never had a lot of opportunity. And so never made a lot of money and couldn't save for themselves. And so now they would, not be able to afford to pay for their own healthcare in their old age, particularly when they retire. So Medicare is available to them, and you pay for that, right? There is a line on your paycheck that comes out for Medicare. Medicare payments. It's, I want to say 7% these days. So 7% of your wages go towards Medicare. I don't feel so bad about that for the people who are actually destitute, who through no fault of their own wound up, poor, and I'd like to see them taken care of. Medicare does not differentiate between those people and people who were investment bankers on Wall Street and have millions and millions of dollars in their bank account. You're also paying for their Medicare, right? You're paying. You, college student making $10 an hour, are paying for investment bankers, retired investment bankers, Medicare, right? So, but in order to get this program passed, there had to be something in it for everybody. And so that's the way that a lot of policies get passed is there's voters have to believe that there's something in it for them. They're much stingier when they see it as just being for, say, the poor. So Medicare got passed. You have to be over 65 or disabled to qualify. So Medicare Part A pays for hospital and a very limited amount of nursing home coverage. Medicare Part B pays for physician bills. And so if you go to a hospital, you're going to get 2 bills. You may not know this yet. You're going to go to a hospital, you're going to get 2 bills. One bill is going to be for the hospital stay. So it's going to cover the room and the nursing staff and the drugs that you get there. And then you got to get a second bill from the physician who oversaw the care for you during your stay. Part B covers the physician component. Part A covers the actual hospital stay. And then Part B also covers outpatient care. So if you're over 65 and you go to see the doctor in her office, your Part B is going to pay for that office visit. So there's no class distinction. The wealthy and the poor receive the same benefit alike. Part B requires a monthly fee that you have to pay in order to get it. And there's a small wage adjusted or income adjusted rate there, but it's still super cheap. Medicaid, on the other hand, is a program for the poor, right? And so it started out basically the only way you could qualify for it is if you were a child or a mother with an unwed mother with children. More recently, with the ACA, it's been expanded to being purely an income-based. So now if you're male, you can also qualify for it. It does cover all age groups. And I think I said in a previous lecture, a lot of the elderly are dual eligible. They are both Medicare and Medicaid eligible. So if you are old and poor, you will get both Medicare and Medicaid. There's a stigma to this, right? Because in order to get it, you have to be poor. Eligibility is, or the benefits are determined from state to state. So it is a joint federal and state program. So money comes from the federal government, supplemented by the state, and then it's run by the state. So the state of New Hampshire has a Medicaid office, and they determine the benefit in the state. So we saw, so managed care has come to dominate the way that care is delivered in the United States. So you might say, what's the difference between managed care and unmanaged care? Well, unmanaged care, the traditional care, was relationship between the physician and the patient, and the physician basically told the patient what they needed to get done, and the patient paid the physician, and then the physician, sent the patient to the hospital where the physician oversaw the care. Insurance companies would pay a fair and reasonable standard rate to the physician based on the physician saying, hey, this person needed, this kind of exam. So they would get payment. Managed care, on the other hand, so unmanaged care, basically, so there's nobody kind of overseeing the physician and checking what the physician is doing and thinking about the health of the patient other than the physician. Managed care adds a layer of coordination and begins to apply scientific principles and standardization to the delivery of care. So so that's kind of broadly what it is, but how is it different financially? Well, financially, we change the relationship between the patient and the physician. There were a number of different kinds of practices. Let's look at them individually. So contract practice. This is the early predecessor to HMOs. So a business that maybe had employed a dozen people or 100 people might hire a physician, and the physician would provide care to all of the employees as part of the benefit to the employees, and also to a benefit to the organization to keep their employees healthy. Might have a contract with the physician an alternative would be a contract with the physician to provide all of the care that an individual would need including both physician visits and hospital visits. So some flat fee called a per member per month charge or per worker per month, but there would be a fee paid to a physician saying, all right, there's 100 employees. The contract would be, I have 100 employees. I'm going to pay you $10 a month per employee per month. So if there's 100 employees, I'm going to pay you $1,000 a month every month. So you'd get $12,000 in income. Sorry, I got a train going by. So you would have this flat fee, and that's called capitation. Then you'd have, you could also have salaried physicians. Like I said, you could just be, the physician could be an employee of the organization. The AMA was not a fan of this, and only kind of approved of it in railroad and rural areas far from large populations, and because it was hard for a physician in a rural area to make a decent living, and so capitation provides a stable kind of income for a physician in that kind of environment. Group practice began to emerge, where physicians joined together into a group and formed a group practice. This was particularly common with specialists of the same kind of flavor. So you might have, cardiologists form a practice. So, and then prepaid, we'll talk more about that later. Prepaid group plans. In particular, probably the most important variation on this is the HMO. And so, let me see. The emergence of the HMO kind of happened during World War II. And this was it kind of grew out of a capitated arrangement. Where the HMO would agree to take a fixed payment from the employer and provide all of the care for a group. Why is this beneficial? Well, what it does is if I'm taking that, say, $10 a month payment to provide all of the care to a group of employees, my incentive is to make the cost of care as low as possible. So I'm not going to do more tests or more exams than I need to, because I'm not going to get paid any more. That's the beauty of capitation, is it's a fixed payment from the patient, right, or from the employer on behalf of the patient to the physician or the providers, and the providers then have an incentive to control costs. And so the HMO, by 1973, we could see Medicare and Medicaid were exploding in cost. And so the HMO Act came about to encourage the creation of HMOs and capitated payments. These had mixed success early on. But yeah, you can see even in the 70s, we were realizing, healthcare is really expensive. And if we give it away for free, it gets even more expensive. So the 1900s to the present, your book calls kind of the corporate era. This is where we have a lot of competition between insurance companies, hospitals, and so forth. And physicians that had previously practiced kind of as individuals began to come together in groups. Hospitals began to become much more formal and join up into systems of hospitals. So in New Hampshire, we have Dartmouth-Hitchcock is a system that includes Cheshire Medical Center and a number of other smaller hospitals, right? We just had the merger of Southern New Hampshire Medical Center and the Elliott Hospital. Catholic Medical Center formed a system with Monadnock and Huggins hospitals. They're doing this this process of corporatization and consolidation because of competition. Health insurance companies became bigger. They were able to force companies to or force hospitals and physicians to take lower payments. So in order to fight with the insurance companies, hospitals had to become bigger entities so that they could also fight back. So hospitals, healthcare is becoming, medical care is becoming a big business, right? So it's becoming, if you're from the Boston area, Mass General Brigham owns like half the hospitals. Leahy, Leahy, BI, Beth Israel are, forming a system now to compete with Mass General Brigham, and then to also be able to negotiate better contracts with health insurance companies. Despite that, we haven't really been able to see much cost control. So I said at the beginning, or earlier, well, not quite the beginning, but earlier, what do we want from a healthcare system? We want low cost, high quality. Well, cost control is, we've got great quality in the sense of individual services, kind of mediocre coordination of that care, but cost has just continues to skyrocket. So managed care has become the primary vehicle for insurance, and managed care now reviews. The primary function of managed care is to finance, right? So you pay this fixed fee into your to your yeah. Managed care now reviews every benefit that you are getting. So if you're a patient and you're covered by an insurance company that is a managed care organization, which most are now, they're going to review, if a doctor says, hey, Bonica, you need to get this scan, right? Or you need a colonoscopy or an endoscopy or an x-ray. The managed care company has to look at that and say, yeah, we agree. That's a good idea, right? And so usually they're following an algorithm, looking at, best practices. So if the doctor says Bonica has, GERD, which is a acid reflux, so it makes you cough and sputter, then that justifies getting an endoscopy. They stick a tube down your throat to look to see if you've got cancer in your esophagus or in your stomach. But the doctor can't just order that. They have to get permission from the managed care company. And so that starts to control costs and prevent the doctor from ordering frivolous tests. Hospitals and physician groups started to form integrated healthcare organizations to counteract this power from managed care. So the bigger you could get as a hospital system, the less the managed care company could force you to compete. So if there's two hospitals in town, like say in Manchester, there's Catholic Medical Center and Elliott, Blue Cross Anthem could go to each of them and say, hey, which of you will offer the lower price for some procedure? Okay. If Catholic says we'll offer the lower price, then Blue Cross or Anthem says, okay, you get all the business from all our patients. And then Elliott's like, damn, now I don't get anything, right? So I guess I'll have to reduce my costs too. So it's both Catholic and Elliott then wind up reducing costs. But if Catholic and Elliott could get together and form a system, which they did briefly, but now are no longer, but it didn't last very long. But if they could get together, form a system, then there would be just the one system in Manchester, and Anthem wouldn't be able to play Elliott off of Catholic anymore. And so that's what hospitals and physician groups have been doing. So hospitals have been joining together, teaming up and forming hospital organizations. And then they've been buying medical practices so that the physician and the hospital are all one organization. And so when Anthem goes to negotiate rates with them, they don't have anybody else to play off of. And so there's no competition. And so it gives the healthcare provider a better negotiating position. So there's also been a number of other revolutions that are expensive, like electronic health records. When I first started in healthcare, everything was on paper. And over the course of my 20 plus years in healthcare, everything migrated to electronic health records, and those health records are becoming more and more sophisticated. But that's expensive, right? It does allow better integration and better care. So if I go, because I'm part of the military health system, if I get my care over at Portsmouth at the shipyard, that goes into the same healthcare system that I could then go to any other military health clinic in the world. And they'd be able to pull up and they'd be like, oh, Bonica, okay. Oh, I see, back in May 23rd, you got, an endoscopy. Well, let's look at the results there. And it seems to be related to what you're in for today. So, now I have, my records across the system. If you're a Mass General, Brigham has the same thing. If you're get seen at Mass Eye and then you come back to Wentworth Douglas, your doctors in both places have access to the same system, same health record system. So that's super valuable, but it's also super expensive, right? Paper is cheap, but it's not very good if you're, because there's one copy. Okay, skip that. So then we get into healthcare reform. We have a number of kind of what your book calls incremental reforms. We have CHIP, which expands benefits, Medicaid benefits for children. We have the Medicare Part D, which Medicare Part A and Part B had historically not paid for drugs. And so Medicare Part D, which was brought into being by the Bush administration, during the Bush administration, I guess I should say, added a drug benefit to the Medicare benefit. The Affordable Care Act, we had a bunch of kind of precedents for it. That's probably the most important piece of health legislation since Medicare and Medicaid's the creation of Medicare and Medicaid in the 60s. The ACA, Patient Protection and Affordable Care Act, better known as the ACA, also known as Obamacare. And by the way, I've actually heard Obama speak, and he loves that it's called Obamacare. He's very proud of it. So we can call it Obamacare, and it's okay, because he likes it. But generally speaking, we call it the ACA, even though it's really the PPACA. Most people just refer to it as the ACA. This was an incredibly partisan bill. Nobody really knew what was going on. It got passed on a party line vote, and only passed narrowly. The Supreme Court ultimately supported it. And one of the things that it was in question was the mandate. So this is the ACA is essentially trying to create socialized insurance, not unlike Germany, right, or Singapore, where everybody's required to buy a health plan. And if you didn't, you had to pay a penalty. Well, it was ruled that it was unconstitutional to force a American citizen to buy something they don't want to buy and impose a penalty. However, because Congress can tax, the Supreme Court said, well, it's not really a penalty. It's really kind of a tax. Even though they called it a penalty, we're gonna, what they really meant was that it's a tax. I'm being a little facetious, but this is the kind of, the Supreme Court really kind of manipulated the language, really kind of bent over double backwards to approve the ACA and to not block the ACA, because one of the mandate, the individual mandate, was considered a fundamental element of the ACA, and if it had not been passed, it would have been voided if the Supreme Court had not found it to be had not been able to figure out a way to make it constitutional. Then they would have had to strike the individual mandate, at which point the whole bill would have been struck down, because it was such a fundamental part of the ACA. But what they did say was, so part of the ACA originally was that it would force all of the states to expand their Medicaid programs, and it turned out that was not constitutional. But that component of the bill was not considered to be as fundamental to its existence as the individual mandate was. So the individual mandate stood, but the expansion of Medicaid became an option. So last slide, because we'll talk much more about the ACA as we go along. Throughout the Trump administration, Trump got elected in part on his promise to repeal and replace. As we know, that never happened. They did do a few tweaks to it. One of the tweaks was the Trump administration zeroed out the tax, the so-called tax, or really what's a penalty. So if you don't buy health insurance, you have to report this on your income tax form now. And it asks, did you have health insurance? And if you didn't, you get a tax penalty, right? The Trump administration said, fine, we can't get rid of this part of the bill or of the law, but what we can do is reduce the tax to zero. So it used to be that you'd have a financial penalty, right, a tax, if you didn't say, yes, I had healthcare insurance all year. And it was, I forget how much. But Trump basically said, that's fine. You get a penalty of zero. Well, penalty of zero does nothing, right? Nobody cares. So essentially he negated the effect of the penalty. Biden ran on, and a number of Democrats ran on a government option. And so this is, the idea here would be everybody be allowed to buy into Medicare or some variation thereof. That's still being kicked around. We could imagine a Medicare for all, which would really be basically the Canadian, system, which is, government provided, government tax financed, government insurance, payment by the government, delivery by a private, by the private sector. So lot yet to be resolved. This is an evolving thing based on, culture and history and so forth. All right, long lecture. This is it for chapter 3.